Hello, everyone, and thank you for joining us. My name is Amanda Kramer, and I am the Alumni Engagement Program Manager at the University of Colorado Boulder's Leeds School of Business. These are certainly trying times, and here at CU Boulder, we have gathered our world-renowned faculty and alumni to provide frank and timely insights for life during and after the COVID-19 pandemic. Today is the first of 7 webinars in this final spring COVID-19 related webinar series. To view upcoming webinars, please visit our website at colorado.edu/business/alumni. Click the drop-down arrow and click Attend Online Webinars. For today's webinar, we're so excited to have Associate Professor of Integrative Physiology and Director for the Public Health Certificate Program, Dr. Matthew McQueen, here presenting the Epidemiology of COVID-19. Where do we go from here? A few housekeeping items before we begin. First, if you have any questions now or during the presentation that you would like to ask Matt, please send a question through the chat interface. We will monitor questions as they are submitted, and Matt will respond to them at the end of the presentation. As a reminder, for optimum audio quality, we do have everyone on mute except for myself and our speaker. If you experience any technical difficulties during the webinar, please notify us through the chat interface and one of our support specialists will touch base. Lastly, a link to access the webinar recording will be sent to all registrants tomorrow, along with a survey link and supplemental resources from today's presentation. Now, I'm excited to introduce today's speaker. Dr. Matthew McQueen, Doctor of Science, is an Associate Professor of Integrative Physiology and Director for the Public Health Certificate Program on the CU Boulder campus. Dr. McQueen is an epidemiologist by training and is engaged in a highly interdisciplinary research program. He teaches Introduction to Epidemiology for the Public Health Certificate Program, as well as Introductory and Advanced Biostatistics for the Department of Integrative Physiology. Welcome, Matt, and thank you so much for being here. I'm going to hand the webinar controls over to you now.
Okay, thank you for that, Amanda. Appreciate the introduction. And again, this is a real pleasure to be able to speak with all of you on through a virtual space here. And today we're going to talk a little bit about the epidemiology of COVID-19, and in particular, not a little bit of how we got here, but then really where things are looking into the short term and more long-term future. So again, as the introduction noted, I'm a professor here at CU. I actually am also an alum, graduated from CU in the mid-90s. When I returned to campus after approximately 10 years getting graduate work at the University of Washington and Harvard School of Public Health, come back to the campus and noticed that there still wasn't public health curriculum on this campus. So one of the things that I was excited to develop was this public health certificate program, which is obviously something that is incredibly timely at this moment. Okay, so first, just briefly, what is epidemiology? And again, we think about this as the study of determination and determinants of health-related phenomena in human populations, and the application of this study to control health problems. An important thing I'd like to note, this is a quote that I like that came from 1957, Jeremy and Morris. Epidemiology is the only way of asking some questions in medicine, one way of asking others, and of course, and in no way at all to ask many. And so epidemiology finds its role in the context of studying, biomedicine and human health, with an important focus on the control of infectious disease. When we start thinking about epidemiology, one of the more foundational aspects of epidemiology is the epidemiologic triangle. Relevant for a lot of diseases and disorders we study, in particular for infectious diseases, we want to ask questions such as who, what, where, and when. And this is particularly relevant at the beginning of a pandemic or an epidemic or an outbreak that we see in infectious disease, where we have to understand, who is getting infected, who is getting sick, unfortunately, in some cases, who may be dying, where this is happening, are there particular environmental conditions or settings that create a problem for us, and then what the agent is, right? Is this a virus? Is it a bacteria? Is it, parasite? And then the central theme of this, right, is time, right? Time is always a factor in terms of when we think about exposure and how that exposure may impact our trajectories of illness. So we'll start with a discussion on the agent. We obviously all know this. SARS coronavirus 2, which is it is a virus. It is in the family of coronaviruses. There's currently 4 to 5 that circulate regularly among humans that really don't, on average, don't have a substantial impact in terms of health. These are, a quarter of which, may cause the common cold. Corona is the term that scientists used just when they initially discovered the virus through a visual microscope. Noticed this crown-like structure. SARS-CoV-2 in particular has some unique characteristics that make it problematic for a couple reasons, and that's really where we are and where we'll focus going forward. It replicates, and the nasal passages, upper airway of our airway system deep within the lungs. This contributes to both the transmission and clinical severity. So obviously when you have a viral virus replicating deep in your lungs, that's what is causing this severe respiratory emergency within individuals. But also the replication and probably the viral shedding that occurs up in the upper nasal passages is what's contributing to the high contagiousness of the SARS coronavirus 2. The other aspect of this that's quite challenging about this agent is that it's remarkably stable outside of the body. There's been studies that have shown, plastic and stainless steel, if the viral particle is on these surfaces, it can last 1 to 3 days. Cardboard, anywhere up to 12 to 24 hours. Copper surfaces and aerosol, 3 and 4 hours. And again, that stability comparatively to, what we might see from a seasonal influenza virus, right, is a lot more stable than what we're used to from those what we're more familiar with. Transmission, again, this, leading into this, we have to deal with both direct and indirect transmission. And direct simply means we're talking about person-to-person contact. That would be inhaling a droplet from an infected person, for example. We can have indirect pathways as well, which there's some intermediary source, maybe subway handle, buffet utensil, doorknob, etc. And so while it doesn't appear as though indirect is the majority of the transmission that we observe, at least in some of the outbreaks studied, it is certainly a measurable form of transmission that we have to be concerned about. So not only do we have something that has a fairly high viral load in terms of shedding from the nasal passages, once it escapes, right, it can escape from person to person to infect another individual, but also if those droplets or that viral particle ends up on a surface, it can remain there for quite some time. So that obviously creates some challenges in terms of thinking about how we might want to control this. This is broadly speaking, when we think about progression of an infectious disease from an exposure all the way down to what we might see as clinical manifestation of the disease or the infection. There'll be a degree of individuals who are exposed who are then infected. This is sort of the infectivity of the virus, and so we can see that first step from this gray down to the orange. Well, again, not everyone who is exposed will be infected to this. Another step that is very concerning with the coronavirus and SARS-CoV-2 is that there's quite a substantial number of individuals who are infected but who do not manifest the clinical disease. This creates problems. Again, it's in a way good news for those who are infected who are not sick, but in terms of control and understanding the real extent of this from an epidemiologic perspective, it's difficult to know how many are asymptomatic in terms of our population. Estimates range. It seems to be dependent upon age, but you can have anywhere from up to 50%, even in some younger age groups, maybe even 75% of people will not exhibit symptoms even though they are infected. If we look at an example, for example, of SARS-CoV-1, the very first coronavirus that was identified in the early 2000s in China, the relative balance between the infected and clinical disease was close to 1-to-1. If you were infected, you almost certainly would exhibit symptoms, and obviously that's not the case here. Then we have to worry about more of the severe outcomes of this, getting sick, maybe more mild course, but then there are individuals who are experiencing quite severe reactions to this, and So we see, concerns about intensive care unit beds and so on, and that's reflective in the severe illness. And then of course the ultimate severity, right, would be death. And so we hear estimates of case fatality rate. We always hope that when we approach a new infection or a new outbreak that we won't have to report case fatality rate. We might just have to report virulence. When deaths start to accumulate, we have to then encounter the case fatality. One very challenging aspect of this, as we just mentioned, really relates back to this iceberg concept of infection. So again, you've got a large number of individuals who may be exposed. Some of them will acquire the infection. After that infection, we've got one of two ways. We can sort of show symptoms for that infection, or we can become asymptomatic, which means we've got the infection, but we're not exhibiting any symptoms, or we feel fine. And based upon all of this, right, we can then start testing. And so this is sort of the first sort of hint at why testing is so important, especially for a disease that has such a high asymptomatic rate. Again, we've got testing properties that are problematic as well, whether we've got false negatives, which would say that these individuals who are infected are not sick with the virus when they actually were. That's a false negative. And then what we see, right, on the surface and all the curves that we see that are published and all the reports that are out there, right, are really just the true positive tests that we can see. We know, now we know, we don't have to hypothesize, but we know that there's a large amount of infections that have occurred and are currently occurring that we are not detecting. And so that's another large challenge to the task at hand. One of the other aspects of this virus that makes it incredibly difficult in terms of containing spread is that it's found to be hit its maximal infectivity right around 1 day or at the onset of symptoms. And so this curve, they studied a series of patients out of this particular study. And on the x-axis here is the days after symptom onset. Day 0 would be when individuals on average reported when they actually felt ill with clinical symptoms. And you can see that infectiousness, that peak of infectivity, right, it happens right before those symptoms emerge. And so again, why is that problematic? Well, you've got people who don't know that they are sick or don't know that they will become sick, who are interacting with others and likely providing an opportunity for further spread of the virus. In comparison to perhaps other infectious diseases that we know about, most often you'll see peak infectiousness either right at symptoms or shortly after symptom manifestation. And so, for example, the seasonal flu also can be slightly infectious before symptoms, but peak infectiousness would be right when the individual is experiencing the most symptoms. Now, onto the host. Obviously, this is us, and so what goes on now? Once we initially discovered that this agent's out there, it's transmitted. Even remarkably, even in January, there were false reports that they were unsure if there was person-to-person transmission. So just think about how far we've come from January to May, understanding the transmission patterns of this. To then we have to understand who's getting sick and who's getting severely sick and who's the most vulnerable, who's the most susceptible. And so, this is just a graph from the CDC, just to show you an example. There's lots of ways that this is getting sliced up in terms of what we understand about the at-risk population. But we know, again, right, that age seems to be a strong risk factor. And again, is it just chronological age? Well, probably not. There's other factors that have to do with age, right? That, we understand that with advancing age, right, there's maybe accumulation of comorbid conditions as well. But you can see, again, this is just looking at hospitalizations for COVID-19. And again, the burden of hospitalization really falls among older individuals in our population. Again, this is we march through this from an epidemiologic perspective, trying to characterize further who's getting sick. We look at the big ones. And again, what's interesting about this, particular virus this is again looking at hospitalized patients. This is now in New York City, where males, and again this is a pattern that we've seen worldwide now, that males seem to be experiencing more severe outcomes compared to females. It's in this about 60-40 range we see pretty consistently. There were some hypotheses that this was due to things like maybe higher rates of smoking, other types of things that may track with whether you're male or female generally in the population. But there's also some other factors that are coming into play now. They're studying obviously different hormonal influences that may differ between males and females. But again, these are the starting points, right, of saying, okay, who's at risk, and now we can start to study why they may be at higher risk. And then of course, comorbidities. This is one that they saw quite early in the outbreak and epidemic in China, where individuals who were undergoing things like chemotherapy, other sort of immunosuppressive therapies, heart disease, respiratory conditions that were not well controlled. These seem to be putting individuals at higher risk for complications and hospitalization. So again, that the pictures emerging on who's at risk in terms of the host, and then pictures also emerging in terms of the environment. So where does SARS-CoV-2 kind of optimize its spread? We have to approach this both physical environments, biological. Unfortunately, we're seeing a lot of socioeconomic factors play in here as well. We certainly see it with occupation, as I'll talk about with things like meatpacking plants. Physical, the climate aspect of this is we're still watching very closely what's going on in the southern hemisphere, for example. Does it pick up in areas that are going now into their winter? Is it going to slow down in our summer in the northern hemisphere? These are questions that we're really trying to follow closely. And again, if we look at some of the patterns here, so some of these studies again that I'm showing are, some may be preprints, but these are some that have kind of been based upon real sort of documented evidence of transmission. This is a particular restaurant where they looked at the airflow pattern, for example, in this restaurant. And so it was a fairly crowded, poorly ventilated restaurant with a number of people eating lunch. And again, the only pattern they could emerge, for example, from this particular restaurant was that there was an air conditioning that would blow the air, sort of at the top of the room, and then there was a air return that would pull it back, and so it kind of recirculated the air across these three tables. So one individual who was sick, sitting in this middle table, ended up getting, I think it was 7 or 8 other individuals in that pattern, in that airflow pattern. And so again, that was sort of evidence that there was some aerosolization of the process as well, beyond just droplets. But again, these droplets can catch a ride on fast-moving air in small places. This one was another one that recently came out, a very high attack rate at a choir practice in the state of Washington, where in this one index case, infected essentially 87% of the entire choir. And this is when they were trying to be careful. They were trying to actually, they knew that this could have been a problem. Obviously, the individual didn't know they were sick and was going to spread it to these other cases. But again, this was an example of, probably someone, everyone who's singing, right, and maybe raising their voice, which could accelerate the droplet transmission in other individuals in a smallish enclosed space. So this is another example of really the environment kind of optimizing the spread. There was, again, this is one just in a preprint stage, but they kind of looked at all these types of examples, the restaurants, the choir practice, a whole number of these things, and really over 98, 99% of these, these transmissions seem to occur in indoor settings. And so this is giving us some clues, right, about how we think about moving forward in terms of what's, what is going to be safe and where we need to worry about our personal risk, but also in terms of the population risk. Now, putting this all back together, when we think about, what are the strategies in looking forward, right? When all of this comes together, right, what do we know? This is a highly contagious respiratory virus. And again, seems to, replicate both in the nasal passages, but also deep in the lung, which then obviously contributes to both the transmission, but also the severity of illness. We are starting to learn more and more about at-risk populations. It goes obviously a little deeper than age, and certainly within those age categories, we'll understand what it is about age that may may result in somebody being more vulnerable. And then environment, the clear pictures emerging on environment, indoor, crowded, poorly ventilated spaces, and time gets thrown in here because again, it's not just walking through these types of spaces, but actually residing in these spaces for extended periods of time. And so that's kind of what we're up against, right? And so where do we go from here in terms of thinking about, what our strategy is for moving forward, which is complicated. I put this quote, this is a quote that I use in my statistics courses and also my Introduction to Epidemiology course, which I love to come back to, which is all models are wrong and some are useful. And what is meant by that really is we've seen all these models that are projected. They all have different assumptions. They're all making certain statements about the future. As we know from any type of forecasting model, whether it's weather forecasting or economic forecasting, right? None of them are going to be exactly right. And it depends on how we categorize what we deem as, accurate or inaccurate. The hope is that we come through this with models that'll be useful and help guide us into what the decisions we can make going forward that keeps the public safe. A lot of these models are get at this this issue of kind of the force of infection, which again comes back to this reproduction number, or R naught. The reproduction number really gives us this measure of the intensity of the spread. How quickly is the agent going to spread through the population? I want to put an important caveat to this. It's highly dependent upon the environment and the control measures we have in place. So again, you talk about an R naught that might be in an indoor, poorly ventilated, crowded space. That R naught could be much higher than, for example, the R naught of a park, a low density kind of outdoor park setting. So again, with R naught of 1, if we think about the chain of transmission just going from person to person, right? We don't ever really achieve with an R naught of 1 of really an episode or a sort of spike in cases, if you will, because essentially on average everyone's getting about 1 person sick, right? Doesn't mean it's sort of something that's propagated. It's there, almost an endemic feature to our population that is just kind of in more of a linear frame as opposed to something that's more exponential. When we move to an R naught of 2, right, you can start to get the picture. Okay, 1 person gets 2 people sick, each of them get 2 people sick, and so the chain moves forward. And then you start getting in the realm of R naught of 3, and again, you can see, this can move very, very quickly. The higher this reproduction number tends to be. What is the reproduction number for SARS-CoV-2? Well, we're still trying to unpack that. It, again, really dependent upon the environment we're noticing. There was a study on the Diamond Princess cruise. This was the cruise ship out of Asia in February, where the R naught, they estimate, was somewhere in the range of 14, which is that is a remarkably highly contagious agent that 1 person can infect 14 other people. The CDC's looked at all the different ranges that are out there, different reports from different studies. And again, the median R naught that they found was around 5. Again, that's 5.7. That is remarkably high. It's likely driven, this high number is likely driven by a lot of these outbreaks and epidemics, regional epidemics that occurred from these indoor spaces that were poorly ventilated and really drove up the contagiousness. But you can see here on this list, here's a comparison of other R naughts for other things that we know. Sometimes the seasonal flu right, is not terribly, contagious. Sometimes it will be closer to 2. Measles is one of the more contagious things that we've known in terms of infection. And then polio and others are there as well. And even in this list here, right, 1.5 to 3.5, there's a huge difference between 1.5 and 3.5. We're still settling on what that number probably is. In Colorado, just to give you an example of how R naught changed over time, this is from the state's database. But again, right about mid-March, when they started looking at the early phases of lockdown, sending kids home from schools. This is when the University of Colorado went remote. This was right at the point where this curve was starting to spike up, where the reproduction number was much greater than 1. And then these distancing measures that were put in place, the more restrictive ones, stay-at-home orders coming in later in March. And then the goal is, right, when you do this, you hope that that reproduction number starts to drop off. And in fact, it probably achieves somewhere in that 0.8, 0.7, 0.8 range, which is good. We want a reproduction number that's lower than 1. And so that was reflected in the data. Whenever you see the curve starting to round the top and come back down, the achievement of that population was that the reproduction number had to have been less than 1 for that to occur. And so we're seeing that, in Colorado, but we're also seeing that in New York and really, across the country and other parts of the world as well. So, the future of this is, there's sort of the big view of this, and then there's going to be more specific views in terms of regional differences and all of that. Really, the 3 scenarios that most experts believe will play out. Scenario 1 will be going through some peaks and valleys. So what we just went through in terms of that peak that we all saw that was scary, and we had the issues with lockdown and stay-at-home orders, right? That just, we have a little break, and then it starts to peak back up about the same height, right? Over time, that peak starts to get lower and lower, right, over the course of 18 to 24 months. That's one scenario. The second scenario, which I think is probably the most concerning for our healthcare system, and most concerning in terms of just the demand and the stress on the economics and other aspects of life, is that we've got this surge and a fall peak. Right now, I think it's too early to tell whether that's going to happen. This is something that we see often with influenza pandemics. We've seen it in 1957. We've seen it obviously in the 1918 scenarios as well, where there's this little hint of kind of what's to come, and then there's this overwhelming second peak. Scenario 3, which I think would be kind of ideal, is that after this peak that we've now come through, or down the peak, we see these lower kind of regional, maybe hotspots of activity that kind of pop up and then go back down without a whole lot of disruption to work life and so on. And so again, whether or not we believe scenario 1, 2, or 3 are going to occur, we're still gathering data on that this summer. It's frustrating to say that, but that's the reality. We have to see how this thing behaves under different scenarios. We want to see how it looks when seasons change. That's why we're watching, again, the Southern Hemisphere. Those types of things are going to be important for us to take into account. What you don't see here, of course, is the most optimistic scenario, which would be somehow, and I think this is a very remote possibility, somehow this burns out before it has a chance to kind of reignite. And again, that may be achievable. I know that places like New Zealand, South Korea have done a good job at keeping this down. I think it's going to be much more of a challenge in this country and large parts of the world to achieve that for any sustainable amount of time. So what's the goal? I think the goal is going to be, we need to keep the reproductive number at a manageable level. We're not going to get it to 0. To do this, I think we're going to need to maintain some distancing strategies. If we think about what you've been doing and you start to expand that out, and maybe you overlap with friends and you're doing things outside with them, and but also, maybe not going to cram into a 2,000 person, club, poorly ventilated and indoors and all that kind of stuff. There's the classic, wear masks, wash your hands, clean surfaces. Those are ways absolutely to keep transmission down. We also need to incorporate robust testing, and we need to rapidly respond to outbreaks. And of course, in the backdrop of this, we need to continue to understand who the most vulnerable are and continue to unfold that story to be able to protect those. And obviously, we've got some obvious examples of long-term care facilities and so on, but there could be other characteristics that we come to learn that would fall into that category. So again, you're going to see these types of messages. Hey, how do we prevent this? Avoid close contact. Don't touch your face or eyes. Practice social distancing. Wash your hands. Wear a mask. Here's how you wear your mask if you're wearing a cloth mask. There's lots of great studies, including a lot coming out of CU Boulder in the next couple of months on how effective masks are for inhibiting transmission and so on. And so these are things that we're going to be working through really throughout this summer. Testing. Where does testing fit in? As you might imagine, we would love if there was some bizarre, really sort of harmless type of indicator that you've got the infection, and so we could know that you're infectious and you should stay home, and so on and so forth. But again, this with so many asymptomatic cases, it's very difficult for us to know who's infected without really robust and adequate testing. This is a bunch of these graphs here. You see these float around, but these this is sort of symptom onset here is this big dotted line. Right, and so right after your symptoms onset is about the peak time when you can detect the infection through what they call polymerase chain reaction, which is just a way to amplify the viral particles that were collected through a swab. Obviously, as your infection improves, right, the detection of those viral particles will go down. They don't go to zero. So when you hear about somebody tested positive, then they tested negative, then they tested positive again, there's a lot that could play into that in terms of, kind of the accuracy of the test, especially when you get further and further out in the course of illness. And then another important aspect of testing is going to be antibody detection. And so we do need to understand, since we can't capture everybody at once, who is, who among us in the population have been exposed to this, didn't know it, infected to this, didn't know it, and have actually generated a robust antibody response to this. And so again, this is going to be one that we have to, watch closely. There's been studies that have just come out, out of LA County, other parts of Spain, and so on, that put the number of individuals who've had an infection many-fold higher than those who we know about, right? And again, that's back to the iceberg concept. We certainly know that that's going on, but we to the degree of which it's going on is what we want to study. And then contact tracing. This, for example, this is a graphic that we put together in terms of how we are thinking about our ability to respond in collaboration with folks at Wardenberg on what CU Boulder is going to do in the fall if a case is identified, and how we have to trace contacts and so on. And so for those who are defined as a case, we need to be able to isolate them. We need to identify contacts and ask them to quarantine. And again, testing obviously is central to this, because again, we can move people in and out of this quarantine situation based upon the adequate and accurate testing. Broadly speaking, if we sort of wrap up, how do epidemics end? How does this all end? Two different ways these things end. The agent, right, SARS-CoV-2, just simply runs out of fuel. And there eventually there's not going to be enough susceptible people to infect. It could run out sooner than the total population. We don't know if there's different susceptibilities among individuals. But the idea is that we get to a point where we build up what I'm sure you've heard discussed, this herd immunity. And essentially what herd immunity really means is just that there's just you've deprived the agent of susceptible host to infect. Usually that's through enough of the population who've already recovered from the infection, and so they have antibodies to it, and so that would not be a susceptible host. Or something happens to slow or stop the transmission of SARS-CoV-2. So again, this would be perhaps in the vaccine realm, right, where we can then sort of, artificially, right, in an active way, deprive SARS-2 of hosts to infect. And again, vaccine development's a very complicated process, but the good news is the entire world is working on this at a pace and a rate that I've, really is unprecedented. Matter of fact, there was a study published, preliminary study published this morning, just this morning, from a phase 1 trial. It was 8 individuals. The vaccine, which what you want to see, the vaccine seemed to be safe. The dosage they used did generate an antibody response, and that's what we want to see. We want to make sure that what we're doing, actually, the body is turned on to be able to respond to this. And so they are now approved to move to phase 2, where now they're going to look at a larger population to understand additional issues of side effects. They want to understand further the immune response. Are there different dosages that give a better antibody response than others? And then, of course, the goal is to get to phase 3, where, again, we can then look for whether or not this works, right? Deploy it in populations. The timeline for this, again, you've heard, people like Dr. Fauci out there talking about, 12 to 18 months. And again, I think that we'll probably have some good indications, right? Phase 1 success stories will turn into phase 2 success stories. We could start hearing about phase 2 success stories by the end of summer, early fall. And then we'll start hearing about phase 3 being deployed in the fall. And hopefully, if one of these that are early is successful, then you could be thinking as early as the end of fall, I think in terms of before 2021, a vaccine being approved and ready to go. Doesn't mean everyone will have it, but again, it'll be have moved forward. So summary, unfortunately, the reality is we're going to need to learn to live safely with SARS-CoV-2, at least for a little while, with the hope that maybe a vaccine comes along. We need to continue to protect our most vulnerable, and I say that, and we can think about drug development and treatment therapies as well in that domain. We need to strategize on how best to keep this reproduction number manageable. And we need to work together and, of course, support each other, right? So again, this is not something that, we're all just going to tuck away in our homes and worry about. If we're talking about getting back to work, getting schools going again, it's going to take really a community and population effort to get this going. And so with that, again, appreciate everyone tuning in, but I'm happy to take questions and generate some discussion. And I think, Amanda, you will take it from here.
Yes, great. Thank you so much, Matt, for that informative presentation. We will now move into Q&A. Please feel free to submit your questions through the chat or Q&A interfaces, and we will ask Matt. We have a lot of questions coming through already. Mary Ann asked, you talked about an estimated timeline for the vaccine. Can you talk about what the estimated percentage effectiveness of a vaccine might be?
Yeah, it's a great question. So, obviously the ideal scenario is, that it's perfectly 100%, effective. And so if you had the vaccine, there's no possible way you can get infected. We just we quite frankly don't know yet how that'll look. The good news is, as an RNA virus, RNA viruses love to mutate. They mutate quickly. The good news is that they're not mutating. They don't typically mutate in the areas that you would develop a vaccine for. And presumably, if we're generating an antibody response that can respond to a challenge from an actual SARS-CoV-2 infection, it would afford you at least partial immunities, and it could be a situation where it could feel like the common cold, or you just feel a little lousy, but it kind of wards off that more severe, virulent track towards concerns with hospitalizations and so on. But right now we don't know. And I think, that's what those phase 2 and phase 3 trials will tell us. The first step is, can we get something vaccine wise that'll generate an antibody response? Great. Yes. Next step is, what do those antibodies do? How much does it protect us? And we should be able to learn, right, from people who've recovered from the infections in terms of, their sort of antibody response and challenges that we could present with them as well in an experimental setting.
Great, thank you for that. Next, we have a question from Kathy. Is the virus mutating, and is there information on whether or not a person can be reinfected?
Yeah, great. So really closely linked to, I think, the previous question. So it is mutating. Almost all viruses mutate to a certain extent. RNA viruses like to mutate even more so. But again, it's this idea that the mutation could lead to more severe sort of symptoms versus mutations that would lead to being more contagious. All those things are still very much up in the air. It's unlikely, for example, if it were to, typically there's a balance for a virus for its spread, that if it's mutating in a way that makes it more contagious, it's probably less severe. That's just on average, because if it mutated to become more severe in terms of clinical perspective, then it would probably wipe out hosts faster than it can replicate and transmit to another host. So you think about examples, more severe viruses, hemorrhagic fevers, and so on in parts of the world, such as Ebola, where it has such a profound impact on the host that while it can result in an epidemic, depending upon the environment, it really needs a lot of fuel to get going, because again, it has such a severe response in the host. And the second part of that, so reinfection. And again, I'm hopeful. The early reports of that with limited numbers seem to be, for example, someone tested positive initially at a hospital. They tested the person 2 weeks later, they were negative, and then another 2 weeks later, they tested positive again. Those look like situations where, again, the methods, these PCR methods are very powerful at amplifying whatever's there, and it's probably amplifying inactive or dead viruses at that point. Currently, we don't have any evidence to suggest that you are, going to be reinfected if you've already been infected with this thing. If this follows what we've known from SARS-1, what we've known from other coronaviruses, that if you've been infected, you probably have a pretty robust response immunity to this for at least a year or so. It may start to degrade slowly from a year to maybe out to 5 years, but currently I don't see anything out there that would suggest that this is something that you would not have, close to full immunity for. At least what you would kind of deem as, you may kind of feel a little sick, but you certainly wouldn't get a super severe reaction to it after, within that first year. But again, these are studies that are ongoing that hopefully we'll be able to answer, because if, the vaccine development, all that stuff, really rests on the ability for antibodies to take the severity off of this.
Okay, great. Thank you for that comprehensive response. Next, we have a question about people who are asymptomatic. Jerry wonders, first of all, what accounts for the high number of people with this virus who are asymptomatic? And then if there's such a high percentage of asymptomatic cases, would that mean that the reproductive rate could be much higher than that 1 to 3 that you showed on your slide?
Yeah, great question. And so, unsatisfactory answer about why are some people asymptomatic. We really don't fully understand that. There's a lot of the immune system that we don't understand. This is one of them. There's some hypotheses, especially among children, in terms of why children seem to be less affected with this. That has to do with kind of the expression of certain T cells during stages of development that may just be a little more robust to responding to this type of virus. And, generally speaking, immune systems that as you grow older, right, the immune response we know is less robust with age. Why you've got a 55-year-old person who's, undergoing, maybe treatment for leukemia, who's asymptomatic, and then these types of things, we just don't fully understand or appreciate. And it's going to be, that's going to be something we need to unpack fairly soon to try to understand who is asymptomatic. And then moreover than that, really dig in a little deeper about, well, was it really asymptomatic or was it more kind of a mild symptoms, reported? We're seeing, again, fascinating stage of discovery now, discovering things like COVID toes and, this loss of taste and smell, things that we never would have thought, 3-4 months ago would be something we'd be studying. But now we need to understand if a child had no symptoms, but then they're starting to see, these blisters on their toes. Well, obviously that wasn't completely asymptomatic, but it was asymptomatic for the respiratory complications. So the clinical picture will continue to unfold. And Amanda, the second part of that question was?
The second part was, would the reproductive rate considered to be
yes, absolutely.
higher?
So yes, that's a great point, and that's absolutely true. So, what they discovered in that Princess cruise ship where they tested everybody was that the reproduction number was closer to 14 because they had a completely closed cohort, so they knew everybody who was infected or who were exposed, and based upon that exposure pattern could test everybody, symptomatic or otherwise. And so, yes, I believe that the reproduction number is going to probably be closer to what the CDC is reporting, which is remarkably contagious in that 5 or 6 range when it's all said and done.
Okay, great. Thank you for the clarity on that. Next, we have a question from Ivy. This fall peak you talked about, how would we pick up on that? What kind of data and patterns would we be looking for?
Yeah, so that's a great question. So what we're looking for, and again, what we're looking for over this summer, we're looking for whether there's, in southern hemispheres, for example, going into their winter, how steep and how, dramatic a peak will they experience going into their winter. We're looking for really we're in the process of trying to calculate the number of remaining susceptible hosts that we have in a population. This is why the antibody testing can be important to understand, if we just went through this big wave, quote unquote, this big wave that we just went through, we've got 10, 15, 20% of the population infected, we know that the peak of that next wave will have to be sort of, essentially limited by the number of susceptible hosts that are left with this. Again, then with our testing capacity to really, get a handle on, the number of active infections that go as we proceed into the fall. And so again, those are the starting points, right? The sort of the initial fuel that's available, the number of susceptible hosts with the number of infections that are floating around will give us a good idea of the potential for how steep that spike will be. And again, it's unsatisfactory, I know, but unfortunately, we just don't quite know which one of those 3 scenarios will play out, and whether it behaves more like a flu, which tends to have a pretty steep second spike, or if it's going to be one of those other scenarios.
Okay, great. Thank you. We're going to move into our final 3 questions. The first question we're getting from a few people, Harry and Terry most recently asked it. Do you have any concerns about the safety of a vaccine that is fast-tracked through the system? Should we be concerned about potential long-term problems for something that's developed this quickly? Yeah,
so and that's a big question as it relates to vaccine development. I think why, and again, it is frustrating. I think why it, again, you could make the argument, right, that, well, it worked in these first 8 subjects in the phase 1 trial. Why not just roll it out and see where it goes? That's, exactly the question that you raised is why we're trying to go through, these multiple phases to develop the vaccine in a safe way. And so you start with these 8, you see kind of the physiologic and biologic response that you want to see. Then you roll it up to a larger number of individuals in phase 2, and then finally into phase 3, where in those trials, it's still an experimental medical trial. There's close monitoring of the side effects, any of the aspects that may be damaging of that is studied, that they will be following through that phase 3 before it's rolled out. But there's always a concern for getting too far ahead of where the sciences in terms of saying, listen, we got to keep, we've got to proceed through these 3 steps safely, and try to balance that with the public demand, economic costs, and all that kind of stuff. So that's a tight window, to kind of navigate, but again, it's one that I think the system's ready for. It can handle this if we don't get too antsy with rolling out the vaccine.
Okay, great. Thank you. Our second to last question, we've received this a few times as well, most recently from Pablo. How safe and what is the efficacy of using convalescent plasma with possible COVID-19 antibodies if you're a patient that has COVID-19?
Yeah, another good question. So there's been actually some remarkably promising results we've seen with convalescent plasma, and effectively, it's essentially trying to piggyback on what an individual had just experienced, which was essentially fighting off COVID-19, developing antibodies for it, and then essentially pulling those antibodies from individual A to help treat individual B. Timing of this, it looks like, is important. You want to try to do this, at a stage. This is why it's so important to conduct the research to understand which individuals may be deteriorating quickly, who could be candidates for convalescent plasma. Again, the way it's done, right, is sort of a sterile. It's not like you're injecting blood from one person to another. But early indications are that it can really give patients a leg up in terms of their ability to fight off the infection. So I think it's a promising lead. And again, we could be reaching a point in this country in the next few months where we identify many thousands of individuals who've actually, whether symptomatic or asymptomatic, have survived this infection, and you can think about plasma donation and so on that could then help the subsequent waves of individuals who are going to fight the infection. So there's some promise there as well.
Great. Thank you for that. And we'll move into our final question here from Stephen. What is the best way for scientifically literate folks who are not in the field to realistically keep up over the next few months in particular?
Yeah, that's a that's a challenging one. I think we're all, I think drinking from the fire hose is the right phrase here. There are a lot of preprints and a lot of kind of initial reports that pop out. The preprint process is important, but as we know, it's not full peer-reviewed literature. The media, obviously, they all are going to have a unique angle that they may take with it, depending upon what the story is. Again, we are just trying to follow kind of some of the primary data collection that's going on, especially as we're learning who's getting infected, the host factors, the serology studies that are coming out as well. There's, a series of, I think some really, well-curated sort of scientific blogs. I think it's sort of a pace that's faster than the publication pace to keep up with kind of the pictures that are emerging on these different entities that are going to be important, right? Testing accuracy and so on. So there's a lot of groups that are looking at, just keep an eye on how, rapid tests for different things and how quickly those tests are going to be available, the serology tests and all that. But I'd have to say, I wish there were one resource that I've been going to for this. But again, I will hit the WHO, CDC, the Johns Hopkins, sites have done a really good job of curating some of this information. But it's really it's moving even faster than, our current information era can keep up with.
Which is incredible to think about. But thank you for providing those resources for us. And thank you so much to everyone for joining us for today's presentation. And a special thank you again to Matt for this great information. As a reminder, all webinar attendees will receive an email tomorrow with a link to the recording of this presentation. To view upcoming webinars as well as previous recordings, please visit our website at colorado.edu/business/alumni. We hope that you will join us for our next webinar, which is tomorrow, as the Leeds School of Business's Dr. Jeffrey York and Brad Werner share entrepreneurial approaches to COVID-19, how to plan, pivot, and persist. In the meantime, have a great rest of your day and go Buffs.